Okay, good evening, everybody. Welcome to this another session of measurements. Today, we are going to talk about M mode, 2D, and Doppler measurements. A little revision from the last class. I'm Dr. Rakesh Gupta from Jorop Institute of Echocardiography. And what we talked in last session, a couple of people were not there. Let me just go a little bit summarize them. Whatever the dimensions we are taking as on today, they are based on American Society of Echo guidelines, which were published in 2015. And we call them as chamber quantifications. And what we look for in 2D and M mode is we look for quantification of volumes, area, linear dimensions of the LV cavity, estimation of contractile function of the heart, assessment of regional wall thickening abnormalities, determination of LV mass, and then monitoring the disease process over a period of time. Now the question is, there are certain definitions are there. One of them is a grayscale, gain settings, transducer frequency, depth of the image, and position of the patient. Now, what is the concept of leading edge to leading edge to trailing edge? This concept can be adequately dealt with this image over here. This is an M mode image across the LV parasternal short axis view at papillary muscles. This is the plaques view at short axis plaques view. This is the two papillary muscles, one on the medial side, one on the lateral side. This is the anterior wall, and here is the posterior wall. If we cut across it, we drive an M mode. So if we're doing an M mode measurements, we take it from the leading edge to the leading edge. And if we're doing from two dimensions echo, we look for a trailing edge to leading edge. Very confusing images, very confusing words are. Now, let me just point out this particular phenomena. In this particular image, look, this is the anterior aortic root of a patient when the echo has been done in plaques window. When we do echo in the plaques window, we take anterior aortic root. This has got a definite width or a thickness. The point which is towards the transducer of this thickness is the leading edge. The point which is away from a transducer is trailing edge. So this thickness, this is what the leading edge is. This is what the trailing edge is, right? And when we measure the measurements in M mode, we'll measure from leading edge to leading edge. This is the image. Here is the leading edge. This is the trailing edge. So we'll measure from leading edge to leading edge. If I'm doing the same thing in two dimensions echo, I'll be measuring from trailing edge of this image, the lower end of this image, to the upper end of this image. Hardly there's a variation of 1 to 2 millimeters when we talk of this leading edge to trailing edge. Now, the question comes, when do we measure what? That is the most important thing is, the measurements are in end diastole or end systole. When is end diastole? End diastole means when LV has become bigger in size, LA has already contracted. That is end diastole. End systole means when the LV has contracted and LA has become maximum in size. That is end systole is. How do we recognize by ECG? That's the important issue is. Recognition of ECG leads to the most important thing is, if you look at an ECG, the beginning of QRS complex is end diastole. End of T wave is end systole. Is that correct? Look, this is a section across this LV cavity. This is the maximum dimensions of LV, the beginning of systole or end diastole. We have a maximum dimensions of LV. At the end of a T wave, we have the maximum smallest dimension of LV, that is known as end systole. And look over here at the same line, if I draw a line over here, this is the maximum LA size what we drive from here. This is end systole. So whenever we talk of systole, whenever we talk of dystole, this is all related to the ECG gating. All right. So what we learned last time was we learned last time was the measurement of LA size. The measurement of LA size is we take a plaques view. Here is a plaques view. We take along the aorta. This is LA. This is LV. RV on top. This is RV free wall. Now look at this. LA is maximum in size. LV is smallest in size. So we have taken the maximum AP dimensions. And look, this is two-dimensional images. We have taken a trailing edge to leading edge. So this is what is the LA dimensions during diastole. We move the same image during systole and diastole or beginning of systole. This is the one point of the LV dimension. This is the second point of LV dimension. We take a long axis cut across this, and that's what we drive is we drive LV dimensions during end diastole. All right. It'll be a little cumbersome for you. Now again taken one more measurements where I've zoomed up. This window is, this is LA dimensions and this is LV dimensions. But LV and LV dimensions cannot be at the same time. Reason is LV will be maximum size when LA is emptied already or end diastole or beginning of QRS complex and beginning of systole. LA would be maximum size when
Excuse me, sir.
end of a systole. So that will be the maximum size of end systole. I'll take up your question at the end of the class.
Okay.
Now, this is a plaques view. We learned about plaques view. We did a cursor across this plaques view where the aorta is cutting RV. So here is RV. It is cutting the aorta. So this is aorta. Is cutting the LA. So this is LA. Now let me take one by one. So if I have to take this size of LV is, RV is, so this is the maximum dimension of LV, RV. So when will the maximum dimension of RV would be? At the beginning of systole. Similarly, this is the smallest dimension of RV. When will be the smallest? At the end of systole. Look, this segment corresponds to a classical end of a T wave. At this end of a T wave, we will find the maximum LA size. At this point, beginning of a QRS complex, you will find the maximum RV size. So we measure RV during diastole. This is the dimensions. And then we measure the aorta dimension from leading edge to leading edge over here. And then the aortic valve cusp separation from this point to this point. That is aortic valve cusp separations. And then we measure the LA in M mode, leading edge to leading edge. That is an M mode dimensions. Pictorial format. This is the leading edge to leading edge of left atrial dimensions. Next important thing is we look at an E point septal separation. So this is EF, this is DE, this is EF. So this is E point and this is septum. E point, this is E point of mitral valve opening. This is septum. This is known as E point septal separation. Normally it's about 7 millimeters or maximum 7 to 8 millimeters or 0.7 to 8 millimeters. And this is 2.12. What does it tell you? That my LV has dilated in mid segments. This is the most cumbersome thing which always I'll tell you to remember. And it's very difficult for most of you to remember. Let me tell you some mnemonics to remember all these kind of things. Look at LA and aortic root. LA is maximum 22 millimeter per meter body surface area. So is the aortic root. Ratio is 1:1. Look at the LV is 32 millimeter maximum size. 22, 32. And then it contracts by 1/3. So if it contracts by 1/3, it remains to 19. Suppose this is 30. So this becomes 20. So remember 22, 22, 32. And whenever we remember my AV valve cusp separations, this is 15 to 26 millimeters. Rest all, the maximum size of my LV wall thickness is about 10 millimeter or 11 millimeter. It varies from books to books. So how do you remember? Remember LA 22, aorta 22, LV 22, and it contracts by 1/3 at least in M mode. That is known as fractional shortening. That 32, 30 becomes 20. And mind my word, these are indexed value. The value of my size, suppose my body surface area is 1.7 and the body surface area of a person with 2.2, the LV will not be the same in size. So we divide by body surface area by doing absolute measurements. Now, if I measure this LV cavity as 60 centimeters, 60 millimeters, or 6 centimeters, I'll divide by my body surface area of 2. So LV will be only 30 millimeters per meter body surface area. Normal, less than 32. Similarly, if my LA size is 40 millimeter, divided by body surface area 2, it becomes 20 millimeter. So LV is normal, LA is normal as per indexed body surface area. Next come word ejection fraction. You know, whenever somebody talks of echocardiography, they only ask for one thing in the word. What is the ejection fraction, man? And that is the most important thing is normal ejection fraction till in this recommendations are in even in 2025 is EF in males more than 2052, females more than 54. That is normal ejection fraction. And how do we say is reduced? 50 to 40, 40 to 30, 30 to less than that. 50 to 40 mild, 40 to 30 moderate, less than 30 is severely reduced LV systolic functions. Now let's look at one by one. I said LVOT, I said LA, I said LV, I said RV. So I'm not going to dwell time on RV first. I'll focus on LV. So my aortic root dimensions is if it's M mode from leading edge to leading edge. And this is known as aortic root. And then we have LVOT, the hinge point of mitral valve, hinge point of aortic valve. Right coronary cusp and non-coronary cusp hinge point is LVOT. Mind my words, both of these leaflets should be opened up completely. And they should be equal in size when we measure my LVOT dimensions. So I said, how much is the LVOT? Sorry, yeah, aortic root and LA. Aorta and LA, they are almost same size. 22 millimeter, 22 millimeters. LVOT dimensions measured at the hinge point of leaflets is approximately 22 millimeter in size. And it varies 18 to 24, 18 to 22, person to person varies, but it's not given any indexed values. Next comes mitral area by fish mouth appearance. Look, parasternal short axis view at aorta. At mitral valve levels, it is a fish-like opening. This is the lateral commissure, this is the medial commissure, this is AML, this is PML. And look, this is a classically fish mouth-like appearance of mitral valve. This is lateral commissure, remember, this is medial commissure. And whenever we do a balloon mitral valvotomy, we are not going to split these valves. We are going to split the commissures to increase the size of the valve. And that's why parasternal short axis view at mitral valve level is the best place where to look for commissures as well as mitral valves. Now, what is the normal mitral valve area? And before that, when do you measure mitral valve area? We measure mitral valve area end systole or just beginning of diastole. That's one take-home messages. Second take-home message is how do you see that we are at the tip of the mitral valve leaflets? We do this by moving our cursor from papillary muscles towards aorta. If you remember when we talked about views, We go from aorta to mitral valve to papillary muscles to apex. Now, in these cases, we'll go from mitral valve, from papillary muscles to mitral valve, so that with the first structure which comes across is mitral valve leaflet tips. My question is, these are papillary muscles. If I move my transducer from papillary muscles to the tip of the aortic mitral valve leaflet, the first structure which encounters is the mitral valve leaflet tips. Now the question is, what is the normal mitral valve area by planimetry? Normal is more than 2.5 or more. Then the classification is progressive, more than 1.5 mitral stenosis, severely reduced is less than 1.5 centimeter, and very severely reduced is less than 1 centimeter square. That's what the guideline says, because they did it like severely reduced versus very severely reduced. And before 2015, it was very simple. 1.5 to 2.5, mildly reduced. Moderately is 1 to 1.5. Severely reduces 1 centimeter square. You have to remember this. Don't remember this. Next comes ejection fractions. Look, ejection fraction is the how much is the blood which is injected by heart in each beat. That is what is known as stroke volume. So what do is, we go to end diastole or beginning of systole. This is a four-chamber view, Mayo's classification, where RV is on this side, LV is on this side. And I'm sorry to say that majority of Americans have adopted a reverse technology. They drive on a left-hand side, opposite directions. They work more with the left hand. So many times they have adopted a technology which is relatively opposite to ours technology. So this is the left-hand side, this is the septum, this is the lateral wall. We start with the septum, trace along with the border, go up at the peak or apex, come back to the basics of the lateral wall, and let the join together the line, and we look at this long axis. Machine divides individually all this system to multiple diskettes and takes a volume, and this method is known as modified Simpson's method. Same thing we do in end systole. So end diastolic minus end systolic volume divided by end diastolic volume into 100 will give me percentage of ejection fractions. In 2024, we are not doing only with four-chamber view. We incorporate also two-chamber view in this particular conditions, so that we are talking of four-chamber as well as two-chamber view in this subset of populations. There are various classification for LV segments. Let me just tell you, like majority of machines still have this 16 segment model. What is this 16 segment model is? This is four-chamber view, this is three-chamber view, this is two-chamber view. Four-chamber view, this is septum, this is lateral wall, this is inferior wall, this is anterior wall, this is posterior wall, this is anterior septum. I told you last time, mid and basal septum, mid and basal inferior wall, RCA, RCA, RCA. Mid and basal posterior wall, mid and basal lateral wall, circumflex, circumflex, circumflex. Rest all LAD, LAD, LAD. Same thing seen over here. And if you put this in a polar map or in this format, look, 50% of the area is supplied by LAD, 25 by circumflex, 25 by RC. And this is what is more important in this subset of populations, where we look at all these things. Dr. Naresh, please switch off your writing pen. So remember this 16 segment model, which will be very useful for day-to-day practice. And even majority of machines, they have not changed their nomenclature to 17 segment model. They are still working on 16 segment model of imaging qualities. One more word, although not at your level, we always talk at level 2. What we do is we look at a tissue Doppler imaging by putting a sample volume at the annulus or medial annulus. And what we draw a graph, something like this. If I have to read this graph, look carefully. This graphs tell you this is beginning of systole, correct? So this is isovolumic contraction time from this point to this point. Then the systole happens. This is systolic interval. Systole happens, stops. Then before the diastole happens, this is isovolumic relaxation time from this point to this point. Then initially emptying, diastasis, it will kick and back to beginning of systole. So this is systolic wave, this is early diastolic wave, this is late diastolic wave. The only positive point is we are getting isovolumic contraction time over here and isovolumic relaxation times. And we do this tissue Doppler imaging in all annulus. 4-chamber view, septum and lateral. 2-chamber view, inferior and anterior. 3-chamber view, posterior annulus. We don't do it anterior septum. And we do in RV free wall to look at RV free wall systolic contraction. Any velocity more than 8 centimeter per second is considered to be normal. Moving on from one strain tissue Doppler imaging to two-dimensional strain of tissue Doppler imaging, we have this modality of global longitudinal strains. And this tell you about segmental thickening of basal septum, mid septum, apical lateral, mid lateral, and basal lateral segments. And it gives you a polar map kind of an area in the same patient to tell you what is the GLS is. So this is one way of looking at LV systolic function evaluation. Now comes the next thing is how to calculate LA area. We did LA volume, LV volumes. We did our ejection fractions. We look at the LV systolic functions. And next person is we look at is LA area. So what we do, when is the maximum LA size? LA is maximum size during end systole or beginning of diastole. We trace this area as we traced in left ventricle, starting from the medial annulus, go around this area, exclude the pulmonic veins are over here, one over here, second over here. Excluding the pulmonic veins, we trace the LA and comes to join these things together to make an LA area. And if I get a length, it will become LA volumes. So I can calculate LA area as we do in LV area. We can calculate the LA volume by adding the length. It becomes LA volumes. Now, one more thing which we are going to talk about in diastole is when we are looking at diastole is we always look at LA volumes. So what we do, we look at an LA volume in 4-chamber view, we look at an LA volume in 2-chamber view, and the formula is 0.85 into area 1 into area 2. Now look at this picture. This is 6.74 is this length. This is 6.15 is this length. And we divide this formula 0.85 into area 1 into area 2 divided by shorter of these two lengths. And we get absolute LA volumes. Then we divide this absolute volume by body surface area. It gives you indexed LA volume. Anything more than 34 cc is considered as abnormal. And those people who have an interest in echocardiography or heart failure, remember, if my LA volumes are high, I am already in stage B heart failure. If I'm a diabetic or hypertensive. You can go to my article published in Indian Heart Journal looking at stage B heart failure in Indian populations. So again, LA area and volumes. Remember, LA area cutoff is 34 cc per meter body surface area. Now, another important thing which is very, very useful in clinical practice. What is this thing is? Let me go back to my previous slide. This is parasol short X-ray view at papillary muscles level. I did an M mode over here. Now, what do? I measure my septum, I measure my posterior wall, then I measure my internal dimensions of LV. Similarly, in systole, I measure my IVS, I measure my posterior wall, then end systolic dimensions. And based on this particular image, machine gives me LV volumes. Sorry, LV mass, not volumes, LV mass. And here is the same picture which I've depicted over here is the machine automatically gives me what? It gives me LV mass at the papillary muscles level. And this is what is RWT. Regional wall thickness is 2 into posterior wall thickness. Suppose my posterior wall thickness was 1.0 centimeter. 2 into posterior wall thickness is 2. Thickness is 1. So 2 into 1 is 2. LV internal dimension is suppose 50. So 2 divided by 50 will become 0.40. That is known as a relative wall thickness. Machine also gives me at the same time the LV mass. And if the machine gives me LV mass, that LV mass, if I plot on this chart, correct. So machine gives me automatically LV mass when I'm calculating it. So what do I get it? I get a reasonable RWT as well as LV mass. And based on these two important things is we come to a conclusion in this by diagram, my LV is 0.42 or less than the relative wall thickness 0.42 or less than that. If my LV mass is less than 95 in females, less than 115 in males, then we consider as normal LV geometry. If my relative wall thickness is more than 0.2, my LV mass is less than that, it becomes concentric remodeling. If it's more than 42, the mass is also more than 95, 115, then we call them as concentric left ventricular hypertrophy. And if one of the parameter LV mass is more, but relative wall thickness is less, we say
सर
eccentric.
रेड लाइन सारी प्लीज उसको हटा दीजिए ना.
Somebody's on iPhone whose volume is on.
नो सर, वो बोल रहे थे कि वो रेड लाइन हटा दीजिए प्लीज.
ये मेरे हाथ में नहीं है red line. Somebody has put on this red line. I'll try. Eraser is not work. Somebody has put this line. And the person who has put on this line can erase it if he wants. Because the eraser is not in my hands. Look, the eraser does not show in my hands. Somebody has put this line, eraser is all off. It can be erased only by a person who has put on this lines. All right.
Sorry sir to disturb. I think if you will click the pen option, then eraser might come.
Okay. Let me try
Can
it
you
here.
try it once?
You want one more?
No, just
Look, this is not going away. This is because this is not been put by me.
okay, sir. Thank you.
All right. Let's move further. This LV mass, what we did was by two-dimensional cycle. If you really want an LV mass, we need to do a three-dimensional cycle and which correlates very well with cardiac MRI. And why the LV mass is important? Because LV mass is important for the reasons that if we have a left ventricular hypertrophy, Patient is hypertensive. We want to see how much the hypertrophy has regressed when we control his blood pressure. And that's how we look at these kind of things. Then what we do is next measurement is aorta measurements. And I'm sure we're not going to talk about this to a large extent. This is level 2 programs. What we have done is I want to elaborate. That's more important thing is we talk of aorta root dimensions. Now this aortic root dimensions is often referred to the hinge point of right coronary cusp and the non-coronary cusps. Then this is sinus of Valsalva dimensions. When this sinus of Valsalva, where we measure anteroposterior sinus of Valsalva. And there is a dimension which is known as LVOT dimensions, which is possibly, I'll say, is a hinge point of right coronary cusp and non-coronary cusps. Same thing like aortic root dimensions versus hinge LVOT dimensions. And some people, what do they is, they go 2 to 3 millimeter inside on either side and then join a line like this to call it LVOT dimensions. But as a beginner, I'd like to say all of you is please do not be swayed away by many people talking many things. Look at the hinge point. I hope every one of you understand what is a hinge point is. Look at the hinge point of these valve leaflets. Right coronary cusp hinge point and non-coronary cusp hinge point. That is what your aortic root or LVOT dimensions could be. And I feel this is the most challenging part of any workshop or any place where we measure the LVOT dimensions. So here is whatever I said is this is the 2 hinge point aortic annulus or LVOT diameter. This is sinus of Valsalva, and this venous sinus of Valsalva joint ascending aorta. This is sinotubular junction. This is ascending aorta. This is arch of aorta. Arch of aorta stands before the segment of innominate artery and the end of left subclavian artery. Then comes descending aorta, and that's how it works when we come of a descending aorta. So I've tried to measure these dimensions. Look at the hinge point of one to a hinge point of another one. Right coronary cusp and non-coronary cusp. That is what the LVOT dimensions or aorta dimensions. This is sinus of Valsalva dimensions. Then, when the Valsalva joined with the ascending aorta, this is known as sinotubular junctions. So this is sinotubular junction, this is ascending aorta, and this is what the measurement is. Then go to the arch. Arch is just beginning of the innominate artery, just before than that, and distal to the left subclavian artery is arch of aorta. And then comes descending aorta. And this view is very useful if a person is hypertensive. I always say look for coarctation of aorta. We often see one at least in 6 months' time, patient presenting with coarctation of aorta and hypertensive for a long time. Now, once we do it, we have indexed value for all of these things. You remember what I said the aorta root was? What is the value of aortic root? 22 millimeter per meter body surface area. That was the aortic root dimensions. So, next going on to right wall thickness. Right wall thickness is subcostal window. We look at the RV free wall. And let me hopefully will say where's the RV free wall is if my picture shows in live. Okay. You measure the RV free wall thickness during diastole, not in systole. And this is at the level of mid RV. Normally it's up to 5 millimeters thickness. I showed you RVOT proximal. This is RVOT proximal, 27 millimeters or more. And hinge point of pulmonic valve is RVOT distal. Again, 26, 27 millimeter in size. This is at aortic valve levels, parasternal short axis view at aorta. This is proximal RVOT. This is distal RVOT. And then this divides into a pulmonic artery, and pulmonic artery is just before its bifurcation. That's what the pulmonic artery is. I showed you last time dimensions. Maximum RV size will be at the beginning of systole. So we join from one hinge point to another hinge point. Maximum is 40 millimeters. Then we take a long axis dimension. Then we take a short axis dimensions. This is how we measure RV. I've seen you over here. This hinge point, maximum RV size, hinge point, long axis, and short axis. Then we move to largest array size. How do we do that? We have to go to end systole, beginning, end of a T wave. When RA is bigger in size, then we trace this area. This is RA area, right? And we can calculate the volumes also by hinge point to hinge point and taken an area and then the length. It'll give you RA volumes. Normally what we do is we look at a long axis dimension and the short axis dimensions of the RA size. So this is a chart to talk you about various dimensions of RV and RV systolic functions. And two important RV systolic functions you have to remember. One is a TAPSE. TAPSE is four-chamber view or focused RV view. Let me go back and show you a picture which I missed and deliberately missed. Look, normal four-chamber view is something like this, where LV is bullet shape, RV is triangular in shape. Correct? Second view is modified RV four-chamber view. Modified is when we get rid of a complete LV, we only see an RV. And third is focused RVRA view. This focused RVRA view is you go to four-chamber view, try to open your aorta and move this image so that RVRA there prominently seen. Look, RV is seen over here also, but this is focused RVRA view. And we try to open our aorta, close aorta, we'll get a beautiful RVRA. Here, apex has been replaced by RV. Look, here apex is not replaced by RV. Apex still lies in LV only. We see a very beautiful view in this. This is known as focused RVRA. Next is measurements or TAPSE. In four-chamber view, we put a M mode and we get how much tricuspid plane, annulus plane, systolic excursion, TAPSE. So we just do a measurement on M mode. Anything more than 17 is considered as normal. Similarly, we showed you pulse wave Doppler flow velocity. Keeping as the septal annulus, we keep an RV free wall tissue Doppler image. So here is systolic velocity. Any systolic velocity more than 9.5 is considered as normal. Fractional area change. We very easily calculate the fractional area changes. We measure RV in, we measure RV in diastole. We measure RV in systole. What is the percentage of fractional area changes happen? That is fractional area change. More than 35 is considered as normal. Then RV free wall strain is not concerned with you. This is another method of looking RV systolic functions. Then I talked to you about RVOT dimensions. My RVOT dimensions are at the level of mitral valve, aortic valve, parasternal short axis view at aortic valve. So what we do get? So we need this measurement of RVOT VTI and RVOT stroke volume. So first, let me go to the RVOT dimensions. As I told you, RVOT is of two types. One is a proximal RVOT, second is distal RVOT. So we can calculate the stroke volume across this tricuspid, across this pulmonic valve. So what we need to measure is measure RVOT dimensions during when you like to measure early systole when it's about to open up. And then we put a sample volume across this RVOT to drive RVOT VTI. I'll come to that in a few minutes. And this area, this is the dimensions, D. Divide by 2 will become radius. And how to calculate area from a radius is pi r square into RVOT VTI. They'll give you stroke volume across this pulmonic valve. What is the importance of this? If you have a congenital heart disease, we need to look how much is a shunting happening through this right side and how much is left side. We look at the stroke volume of right side, we look at the stroke volume of left side, and that gives you how much is the percentage of blood which is going more into the RVOT rather than LVOT. All right. Let me stop over here and take your questions. Then we'll have a 5 minutes break and then we'll go further for a Doppler measurement. So I'll request every one of you to come up with questions and I'll be happy to answer all of you. Just give me a second. Let me take out my writing paper so that I can write the questions which you have asked. At the same time, so questions one by one. You can raise your hands. Dr. Shabir. What's your roll number,
Sir,
Dr. Shabir?
my roll number is 20, sir.
Okay.
Sir, could you please show me again how to measure the LA volume and LA volume index?
All right. Can you see my screen now, Shabir?
Yes, sir. Yes, sir.
All right. I'll try to show live now.
Okay, sir. All right. So we can see four-chamber view. Yes, sir.
So I'll get one more picture. Perfect. Now you can see a live images where this is four-chamber view. This is two-chamber view. Correct?
Okay, sir. Yes, sir.
Now I'm going to stop it. I want
Okay, sir.
maximum LA size. So how do I get a maximum LA sizes? When will be the LA maximum size?
In diastole,
The beginning of diastole or end
beginning
of
of
a
diastole.
systole. Look, this is
Yes, sir.
end of a T wave out here.
Yes, sir.
Correct?
Yes,
Now
sir.
I'm going to measure this LA volumes live. So I'm going to trace this area from this point lateral annulus.
Yes, sir.
Machine will join automatically. I've I have not gone into this pulmonic veins. I'm outside the pulmonic veins. Same thing I'll do for this over here. Correct? So
Yes,
my
sir.
area is 21 centimeter, 22.3 centimeter, and there's not variation of more than 10%.
Okay, sir.
So if this is 21, if maximum variation should be 2.1 centimeter, so it could be 23.1 centimeter. We are well within range of 22.3.
Yes,
You
understood,
understand
sir.
that? The variation
Yes, sir.
should not be
Understood,
more
sir.
than 10%.
Okay, sir.
Now I'll take a length. So what I'll take, I'll do a length of this patient as caliper. I'll draw a length over here. One length, second length. Now
Okay,
my
sir.
length, one length is 18.4. No, sorry,
Okay, sir.
5.3, 5.5. So this is 5.3. This is 5.3. This is 5.5. So I'm going to use 5.3 as a dimensions. So my LA volumes would be 0.85 into area 1, that is 21, into area 2, 22.3, divided by 5.3. Let's calculate.
So
0.85 into
sir,
area
the
1.
0.85 is pi, sir.
0.85 is a constant.
Okay.
22.3, that is 398 divided by 5.3. So my LA volume is 75 mil as an absolute value.
Okay, sir.
Now I have to get to index value. And
Divided
if
by
the
body surface.
index value is divided by body surface area. Suppose the index value is 2. So body surface area is 2. I divide by 2, I'll get is 37.5 ml per meter body surface area. It means my LA volumes are large. They are
Yes,
more
sir.
than 34 cc per meter square body surface.
Okay, sir.
Are you
Sir,
clear now?
yes, sir. Yes, sir. Sir, every machine will have this option to trace, sir. Like we have a sonocyte in
All
ICU.
machines have got. In fact, you can ask your vendor to
Okay.
create your LA volume algorithm. So once you
Okay,
do
sir.
this measurement of LA1,
Mm-hmm.
area 1 into area 2, and then you have to see which one is larger. This appears to be smaller. This appears to be larger. So I'll straightway go to the smaller one to get my LA volume. Even this machine has got it, but this is not
Okay.
programmed for that. That algorithm is not there in this software.
Okay, sir. Okay, sir.
All
Thank you
right.
so much. Yes, sir. Thank you so much.
Next question. Anybody has any questions now?
Yes, sir. Excuse me, sir.
Identify yourself. Who are you? What's your name?
Sir, I'm roll number 33, Dr. Anu Yarki. Roll
Dr.
number,
Anu
sir, Dr. Anu Yarki.
33. Okay, all right, Anu. Go ahead.
Yes, sir. Sir, actually, my initial question was about the measurement of LA only, not the area, but the length. I was having some doubt in the earlier slides where I guess you said that we were measuring the length of LA in 2D
I'll
in
show you.
end diastolic.
Okay,
but
I'll come back because that's why I have come back with this echo pack today. That's
yes,
why I wanted to show a live what exactly I wanted to show a live. Give me a second.
yes, sir.
Not a very happy pictures, but I'll try to make it as happy as possible. I'm increasing the gains to a large extent. Now I'm asking this. This is Plaque's view. Look, my aorta is all straight.
Yes,
This
sir.
is horizontal. And I can see my both leaflets opening up, right and non-coronary cusp. So this is RV free wall. This is R RV. This is anterior aortic root. This is posterior aortic root. This is anterior aortic root is condition of interventricular septum. Posterior aortic root is continuation of AML. Then this is right coronary cusp. This is non-coronary cusp. So I'll stop this image and go to one by one at the beginning of what? When is LS is maximum in size?
So it should be end systole.
Correct. I'm here is ancestral now. Right?
Okay.
Now I go to measurement, take a length. So I'll be measuring from trailing edge to leading edge.
Leading edge.
So this is what? 44 millimeters. If you take absolute value, anything more than 39 is bigger. But if this patient's body surface area is 2, 44 divided by 2 will be only 22. So it will be high normal.
Okay.
Got it?
Yes, sir. So another question regarding the previous question, which was asked by, I guess, Dr. Shabir, when you were telling about the area of the LA and in the two lengths which we took, why did we take the shorter length? Why
Yeah,
not
it's a
the...
good question because when people they describe about measurement, look, whatever we do today are being certified by cardiac MRI. So
Okay,
when we are doing something with the cardiac MRI, we have to do something which is almost close to cardiac MRI.
okay,
Correct? So our short of these two lengths, when we took a longer length, we were overestimating our LA volumes. When we took a shorter length, we were normalizing almost close to cardiac MRI.
okay, sir. Okay, sir. Uh, so I have a few more doubts. Actually, the topic about tissue Doppler imaging and the topic about GLS after that, um, I felt it was it was at a faster pace. I didn't
No,
get
no,
it.
it is not at your level. I just touched it. That's what we do in level 2. We we always recommend you to attend our advanced skill training program in the month of August.
Okay, 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 sir.
So
And
don't go with this because I am not telling you to learn tissue Doppler or
yes,
GLS. I
I
was
think it was
delivering a talk recently in Vietnam. I was having a debate on this GLS only.
okay, okay, sir. So lastly, in the last slides, you were talking about the apical four-chamber view, the modified RV
Correct.
view which you're talking. Like, how will we, change that apical chamber view to getting a modified RV kind of view? We have to move the transducer to a certain angle or something.
This is like, I can't tell you like how do we do it, honestly saying, but I can only say that this is comes with a handy practice.
Okay.
Only take home message from this is when we talk of this important thing is look at this three views. I'll show you all three views. I deliberately did not
Yes.
want to
Yes.
touch it.
Mm-hmm.
This is conventional four chamber view where we see LV in the apex.
Yes.
This is bullet shaped LV with a
And
triangular RV.
triangular.
Correct?
Yes. Yes, sir.
This is modified where the LV apex disappears.
Yes.
Now, focused RVRA view is where the LV apex does not disappear. LV apex remains same place. But
Mm-hmm.
we have modified in such a fashion that we are focusing on RVRA. In
Yes.
this, you can't see apex very clearly.
Mm-hmm.
Here you can see it, but the LV apex is gone. Here
Yes.
the LV apex remains at the same place, but RV apex becomes very clear. And this is where the maximum measurements are recommended. So what we normally do is, I always do is, I go a space little bit up in fourth intercostal space. Keep my LV apex as at in normal position, and then try to focus on RVRA. And slight anterior angulation, footprint looking toward the right shoulder tells you the aorta opens up over here. If my aorta is opening over here, I see this picture, I close my aorta, and this becomes RVRA focused.
Okay.
It'll come with the experience. I'm not saying that it will not come with experience. It will come with experience.
Okay, sir. Okay, sir. Thank you.
Right? Thank you.
Sir, Tushar, roll number 25 this side.
Go ahead,
Sir,
Tushar.
sir, in apical view, in four chamber view, sometimes like left ventricle is on left side or right side. It depends on machine, like company of the
No, no,
machine.
no. It's the machine remains the same. I'll just show you one more thing that's important for all of you. Look at this V sign. Did you see this V sign?
Yes, sir.
V word written over here.
Yes, sir.
This word has to be always on right hand side. You put this word on the left hand side, your image will reverse.
Yes, sir.
So go back and see your machine, my V is on right side or not. If your V is on the left hand side, take my words, you are doing a wrong measurements.
Sir, like in the previous slide that doctor was asking about the four chamber view, you were showing that three images uh, of the, like, can you open that slide, sir? Yes, sir. It's this slide. Here, like here, this left. So, like, is this normal or in some slides you show the left ventricle on other side? Like when I try to do left
I'll just
ventricle.
show you. I'll just show you what you're trying to say. Just give me a second. You were saying this.
Yes, sir.
Yeah. This is Mayo's clinic teaching. The index marker which we taught you to keep at 3 o'clock for apical windows, they say index marker to keep at 9 o'clock position.
Okay.
Yeah, it's appendicular side, sir.
Yeah, for this apical window only.
Yes, sir.
So my quest would be like, this is Mayo classical teaching. Not many people have learned from Mayo. So we always say that we keep it from only on right hand side. My LV would be always on this side, RV on this side.
Yes, sir. Thank you, sir. Confusion clear.
Like this way.
If the
And look,
index
even
marker
this V
towards
point is on this side, not is this side. Tomorrow, if you have a machine, just go and do this. There's a button left R and L. So make regular four chamber view and press that button R and L. So image will reverse and this V will go on this side. Okay?
Yes. Yes, sir. Thank you, sir.
All right. So anybody else?
Sir, good evening. Myself, Dr. Arjo, roll number
Arya?
2.
Dr. Arya, go ahead.
Sir, I have a confusion on right ventricular free wall thickness measurement and the RVOT proximal and distal and the measurement of TAPSE and what is its implication. Kindly, please, if you.
Yeah, sure. Just give me a second. I'm coming down. So let me stop sharing this slide, go to a live demonstrations. I think that'll be better for you. All right. Not happy with this. Let me see.
first.
Go to RQ. Let me take out some COPD patient. How do you measure your RV free wall thickness? That's the first and foremost important thing is. Look, this is
Yes, sir.
subcostal window. And in this subcostal window, I'm going to stop this image moving. Then go to beginning of systole. Correct? Now, beginning of systole means the LV or RV has to contract. And RA and LA, they are bigger in size. So what we do is we look at the RV free wall thickness at a point which is midpoint virtually, where the tricuspid valve leaflet opens up. And in this patient, if I have to measure my RV free wall thickness, my caliper will measure, this is my RV free wall thickness, 0.5 centimeters. At the level of roughly mid of RV, during and diastole or beginning of systole, diastolic thickness. Then your second question is, what is my RVOT dimensions, correct? So my
Yes, sir.
RVOT dimensions is, we measure RVOT during, when is RV is maximum in size? Again the same thing,
End of the study.
beginning of systole. So this is what my RV dimensions is. This is what my proximal RVOT dimensions in Plaques view 38. It is bigger in size. Then I'll go to short axis view at the level of aorta. So I'll go to valve. I think valve will give me a, aortic valve will have this short axis dimension, severus. Pediatrics. Kindly bear with me because I'm trying to look at the, because suddenly both of the blue, if I, yeah, it will show. There's three dimensions. I think let me go back to my presentation that has that particular short axis view. So this is RV free wall thickness. Yeah. This is parallel short axis view at aorta. So this is one we measure it over there in Plaques view. This is another one proximal RVOT dimensions. And distal RVOT is at the hinge point of pulmonic valves. Pulmonic artery is just before its bifurcation to left and right pulmonic artery is pulmonic artery dimensions. Remember, this is 26, 27, 27. Almost 26, 27 is the normal dimensions. In live picture, this is parachute short extravasate aorta. This is LA, this is RA, this is tricuspid valve, this is RV inlet, this is outlet, and here is RVOT proximal, here is RVOT distal. All right,
Okay, sir.
Arya, I am able to answer your question. Anybody
Sir,
else?
okay,
Go
sir.
ahead, go ahead.
Thank you.
Good evening, sir.
Good evening, Debangana. Go ahead,
Yes, sir,
Debangana.
from Kolkata. Sir, sir, you were speaking about enlarged LA in diabetics and hypertensives corresponding to
Stage
in
B heart failure.
yes, sir. So, can you please elaborate a little on that? Like only for diabetics and hypertensives with an enlarged LA will be thinking about a ventricular hypertrophy, or like how should we approach for the other people with enlarged LA but not hypertensive or not diabetic?
Otherwise, also, it's normally my LA size anterior-posterior dimension is less than 22 millimeter per meter body surface area. Correct?
Yeah, right.
If I go to my volumes are less than 34 cc per meter body surface area.
Okay, sir.
In pathological conditions like ischemic versus dilated cardiomyopathy, LV and LA, they'll be dilated.
Okay,
Correct?
sir. Yeah.
So, ischemic, valvular like MS, my LA would be dilated. MR, LA would be dilated.
Okay, okay.
So, all these conditions, when we have with established lesion, my LA is dilated, my LA volumes are high. But I'm talking about people who are asymptomatic hypertensive and diabetics. If you, especially diabetics,
Okay.
if you look at their LA volumes, if their LA volumes is more than 34 cc per meter body surface area,
Okay, sir.
it means they have gone to stage B heart failure. If you allow me, just let me show my presentation. One of the presentation which I've said about all these things. It's a very interesting phenomena. Like, I'm not really sure how many people they are really doing it and they have done it. But if you really ask me, tomorrow is not a day for interventions. After 10 years, we'll find more congestive heart failure patients or diabetic or hypertensive cardiomyopathies rather than ischemic heart disease in a time to come. And is not a good statement to say. But that's how I feel is tomorrow, that is a day which is going to happen.
Okay. So
Give me a
that is like you're saying this out of the focused proportion of people going to be
in
hypertensive and
heart
diabetic.
failure. Like 1/3 population is almost diabetic today. What else do you want?
Right.
Hello, sir. Dr. Kailash from UK, sir.
Dr.
Sir,
Kailash, just a minute. Let me complete her answer. Because this is what presentation I did, and it was what I feel is a very important thing as on today in clinical practice.
Okay, sir. Shall we?
Just give me a second because so I could locate one of the presentation. I couldn't locate my presentation. Forget about it. But let me show you one what I have in my mind. Can you see my slides?
Yes, sir.
All right. If you look at this slide very carefully, this is stages of heart failure at risk. At risk means patient who are hypertensive, diabetics, but they have not developed heart failure. Correct? Or they have not elevated biomarkers. Stage B heart failure is when they have a structural heart disease. What do you mean by structural heart disease? Means dilated LA, or they have abnormal cardiac functions, or they have elevated NT-proBNPs.
Okay, sir.
This is asymptomatic. Same patients, if they become symptomatic, they become stage C heart failures. And this is very common today. Look at this diabetic cardiomyopathy. Enlarged LA, feature of diabetic cardiomyopathy. Impaired myocardial relaxation, we get it by GLS, two-dimensional strain, or impaired GLS is over here. Then elevated LV filling pressure. What is this elevated LV filling pressure is? LA pressures has become high, patient LA volume has gone up, and patient is in diabetic cardiomyopathy. So if you look at an LA which is dilated, obviously this is normal in a ischemic cardiomyopathy or dilated cardiomyopathies or valvular lesions, but you happen to see a dilated LA in the absence of any valvular or coronary disease subjects. That is the most dangerous thing you are seeing in this population. And this is not only the things which I'm trying to say is, answer is, look at the population. This paper was published, which I'm going to show you in a second, in Journal of American College of Cardiology in 2013. And I feel this is a more apt paper for our country. Why is very apt paper in our country is, I'll just show you one slide. What does this LA volume tells you in a clinical practice? Slide number 105. Okay. So you can see my slide. Can you?
Yes, sir.
So this is what is the objective of this paper was to determine look at this paper published in JAC 2013, first of all.
Yes, sir.
LA volume index relation to long-term clinical outcome in type 2 diabetes. To determine the prognostic importance of LA dilatation in patient with type 2 diabetes with no history of a cardiovascular disease. All of us understand diabetes is associated with development of cardiovascular disease, and morphological changes in the heart may appear before the symptom arises. You know what was the conclusion of this patient? This study is 12-year-old study. The conclusion is increased LA volume index was independent incremental predictor of cardiovascular mortality and morbidity into type 2 diabetes with no history of a cardiovascular disease. And that's what I showed you in that paper published in 2022. LA volume has become one of the important factor, or dilated LA has become one of the important factor for evaluation of diabetic populations. They don't have any symptoms, but they get dyspneic on exertions, and they have a dyspnea even with small exercise activities. Got my point? Why my LA volumes are important today?
Yes, sir.
I hope I am able to give you an answer.
Yes, sir.
All right, next person. Can we have other person? Somebody asking this question. Dr. Chaudhary, I think you were asking. Anybody else? Any questions?
Hello, sir. Dr. Kailash from UK.
Yeah,
Sir.
Dr. Kailash Motera. I forgot. I'm so sorry, but go ahead,
That's
Doctor.
okay. So you told us when we are measuring the arch of aorta to look for coarctation of aorta.
Correct.
So what would be the findings that we would expect, sir?
Okay. Kailash, if you have a coarctation of aorta, We always do in hypertensive subject looking at the coarctation of aorta. What's your roll number, Kailash?
39, sir.
39. Just give me a second. I'll give you an answer in practical format.
Yes.
It's 208. Okay. Now, can you see the slides?
Yes, sir.
If I have to identify these structures, this is my ascending aorta, this is arch of aorta, and this is descending aorta. Look, and from descending aorta, I'm trying to identify the vessels. This is left subclavian, left common carotid, and this is innominate. So distal to left subclavian artery, there's a turbulence seen over here. This is mirror image. Forget about this mirror image. This is the turbulence seen over here. I'll come back again. Let's show live. Now let's see a turbulence over here. Significant turbulence over here. This is normal phenomena. This is turbulent flow. And once I put a sample volume just before the turbulence, my velocity is only 1 meter per second. Correct?
Yes, sir.
As soon as I go across this turbulence by continuous wave Doppler, my velocity has gone to 3.5 meters per second. So it has got two Doppler spectrum patterns. One Doppler spectrum pattern seen over here, which is corresponding to 1 meter of the flow velocity. Means this is pre-coarctation flow velocity. And this is a flow across the coarctation. So velocity is almost 3.5, 36 millimeters of a gradient. If I divide this 36 minus reduce pre-coact gradient of 4 millimeter, the gradient across coact is 32 millimeter. Anything more than 30 is considered as abnormal. 20, more than 20 is considered as abnormal. So the identification lies from this coarctation from here. And
Yes.
this is adult person. He had
Yes.
come with left ventricular hypertrophy. He had blood pressure which is 220 by 120. He says a very important thing which nobody listened to him. Especially, I'm sorry, we have such a large amount of load in our hospitals that we do not listen. By the patient walks in and walks out, his treatment is done.
Yes.
He was telling my blood, when my BP becomes normal, when 140 by 80 my BP is, I'm not able to walk. Why? Because the pressure which is generated by high blood pressure to flow blood across the squat was sufficing his blood flow to lower limbs. He had 2 renal surgeries done for renal calculus. He had 3 episodes of epistaxis. He had significant left ventricular hypertrophy. Diagnosis, hypertensive heart disease. So my question is, always look for ascending aorta when you are doing a patient evaluation who's hypertensive. Like it could be 1 out of 100, you will find only 1%, maybe 1 out of 500. But that one patient is important.
Yes.
So that's how we look for coarctation of aorta.
Yes.
Right?
Thank you.
Anybody else, any questions further, or let me go back to now next presentation. Part of the next presentation. Unfortunately, last week I was in Vietnam and I had to attend one of the meeting of Eco Asia 2026, and I was debating against global longitudinal strain with one of the finest person in the world to talk about GLS. And topic which was given to me was ejection fraction. And I have to fight against this GLS. Look, GLS is a modality which everybody is talking about. But I say GLS is a modality which is useful, but it's not everything. And unfortunately, my laptop charger got broken down in transportations. And that's how I had a problem of doing this presentation. I hope I'm able to clear your so many doubts today. I hope you're not tired, okay? So let me move on further. Just a second, give me a sec. All right. We are back on track. Now, the next important thing, which is very useful in our day-to-day practice, is not a difficult thing. It's a very easy thing. What we talk of peak and mean gradients, pressure half time, continuity equation, holodiastolic reversal flow in descending aorta, and Doppler calculations. What is peak and mean gradient? Any Doppler flow, look, this is the mitral flow across, this is LV and this is LA, this is Mayo Clinic presentations. So you put a pulse wave Doppler spectrum pattern, pulse wave across the mitral valve, you get a Doppler flow wave. This is E wave, this is diastasis, this is A wave. You trace this Doppler spectrum pattern beginning from baseline to go to top, go across this, just keep on tracing it till the end. And say finish, the machine will give you automatically peak velocity, peak gradient, mean gradient, and velocity time integral. Very simple thing which you have to do. And the classical example for this is mitral stenosis. So what we have mitral stenosis? We have an E wave, diastasis, then A wave. The patient is still in normal sinus rhythm. So I trace from baseline, go up, go down, go up, go down. So this is what is peak velocity, peak gradient, mean gradient, and velocity time integral. As Dr. Parasha said, told you last time, velocity time integral is the distance the blood travels with each stroke. And second is pressure half time. Pressure half time is the time taken by this machine or by this valve to drop to half. Suppose this time pressure is, suppose this is 20, this is, we can say that pressure over here is 16 millimeters of mercury. The time taken for this pressure to drop to half is pressure half time. Means 16 drop to 8, that is pressure half time. And if we divide this pressure half time, 220 by pressure half time, it will give you a mitral area. So what we learned is, put a sample volume across this Doppler flow patterns. In a normal subject, when there is no turbulence, no aliasing, you will find this kind of a patterns. Look, the initially emptying would be there. Gradients, this is mitral valve. What is the maximum velocity, remember? 1.3. Remember two important velocities, mitral 1.3, aortic 1.7. Half of mitral is tricuspid, half of aortic is pulmonary. Now, next subject, look, mitral velocity is 2.4, 0.4 meters per second. Anything more than 1.3 is abnormal. And mitral area by 1.8 by pressure half time method. So this patient classifies it to 1.5 to less than 1.5 would be very severe. More than 1.5 is progressive mitral stenosis. Then come continuity equations. Continuity equations mean the blood which is flowing across LVOT has to flow across the aortic valves, right? How do you calculate the blood flowing across the LVOT? We take an LVOT diameter, hinge point, diameter. Diameter divided by 2 will give you radius. Pi r square will give you area. So we can get the area across this LVOT. Then we need to have a VTI. So what do? We take a pulse wave Doppler spectrum pattern across 3 chamber or 5 chamber to calculate VTI. They'll give you area into VTI will give you stroke volume across LVOT. Now we need to know the area, but we know what is the VTI. We switch over to continuous wave Doppler in 3 or 5 chamber view and we get a VTI. If we divide this equation of area into LVOT, VTI into area at LVOT into VTI of LVOT by aortic valve VTI, will get area of the aortic valve. Let's show how do we do it. Third is holodiastolic reversal of flow in descending aorta. What we do? Again, the ascending aorta, arch, descending aorta. Look, there is no turbulence out here. It's all red in color. So what we did, we put a sample volume in this descending aorta. So we get forward flow and severe AR will get a reverse flow. You must have read, your bosses must have told you to hold your hand up to look for AR. What was that? Running of pulses. So when the severe AR is present, the blood reverses back into the LV cavity. And we see all red color. Normally it should be blue. There should not be any red color. So we see a reversal of flow. That is holodiastolic, means through and through in diastole. That is holodiastolic reversal of flow in descending aorta. Now, again example for LVOT diameter. Hinge point, hinge point. What is diameter? 1.87. Somebody has got a calculator, just open it with the calculator. Name your name and open the calculator. (1.87) divided by 2. So let me just calculate also along with you. 1.87 divided by 2. It will be 0.935. So if I have to calculate area from this, I need to have a square of it. 0.935 into 0.935. It becomes 0.874225. Then this has become radius square. Now radius square into pi. Pi is 3.14. So what we get is area is 2.74 centimeters square. Is it clear? Now we went to three-chamber view. We kept a sample volume in LVOT before the aortic valve and then trace this Doppler spectrum pattern. Look, we are tracing it, this Doppler spectrum pattern. Normal, this LVOT VTI is up to 24 millimeters. Now look at the LVOT VTI, 16.9 centimeter. So multiplied by 16.9, it'll give me a stroke volume of 46 ml absolute values. Divide this 46 by body surface area. Suppose the body surface area is 2. The stroke volume would be 23 ml per meter body surface area. Anything less than 34 is considered as abnormal. Not 34, 35. Now, next step would be, this is stroke volume, absolute value is 74, I believe. 46 ml. If you multiply this stroke volume by heart rate, you will get a cardiac output. Correct? Same thing what I did. Instead of pulse wave, now I kept a continuous wave Doppler spectrum pattern and drive my aortic valve VTI. If my aortic valve VTI is suppose 100, 46 divided by 100 will give me aortic valve area as 0.46 centimeters square. I know it's tough. It's not an easy task, you know. Majority of doctors have never learned mathematics. Next comes vena contracta. We'll be repeating all these things again and again. What is vena contracta is, once we look at the regurgitant flow like this MR over here, we have multiple hemispheres which are made in this subset of populations. Look at this hemisphere, which is yellow in color. Look at this hemisphere, which is blue in color. This is not a true depiction, but the depiction is seen over here. Once the blood flows from MR jet from LV to LA, it forms multiple rounded hemisphere because we are cutting only at one section. So we only see one part of this hemisphere, and this is what the PISA is. The red measurement from the tip of the mitral leaflets to the maximum dimensions of that red color, that is PISA. Proximal isovolumic surface area. And this is what the vena contracta is. Vena contracta is from this point to this point. But we normally do not measure the vena contracta in 4-chamber view. We try to measure the vena contracta in 2-chamber view. So, questions. I know it's a tough topic. Too much in a single day. But I'll try to show you a live demonstration for each and everything. Much more than this, like whatever I'll try to show you. Rajan Verma, go ahead.
Sir, kindly repeat LVOT VTI measurement, sir.
Okay. This is Plaque's view.
Yes, sir.
Rajan?
Yes, sir.
This is aorta. This
Yes,
is
sir.
LVOT. This is RV on top. This is LA. This is descending aorta. So, beginning of systole, we see this right coronary cusp and non-coronary cusp. in the hinge point of this right coronary cusp and non-coronary cusp, this is my LVOT diameter.
Yes, sir.
So if I got a diameter, I can calculate area. How to calculate area is diameter divided by 2 will give me radius.
And pi
And then
r square.
using pi r square will get the area.
Yes, sir.
Then I go to 3-chamber view or 5-chamber view where the aorta is seen. Keep my sample volume, pulse wave sample volume before the aortic valve. I'll get a Doppler spectrum flow pattern. This Doppler flow pattern is very useful in calculating the velocity time integral or TVI or VTI. VTI is velocity time integral is amount the blood pushed with each single beat. So if you trace this Doppler spectrum pattern, machine will give you VTI. So pi r square of this area into VTI will give you stroke volume.
Okay, sir. Thank you, sir.
And this is very useful for aortic stenosis. I know it's like many things must be going over ahead of everybody. I'm not saying no, they do happen. Anybody, any other questions? I know everybody must be half dead, if not fully dead.
Good evening, sir.
Go ahead, Parvez, go ahead.
Yes, sir. Sir, could you just repeat again? How do we calculate the cardiac output again from stroke volume? Sir, the TVI portion I had doubts, which has been cleared right now. So after that, how do we proceed to
You
calculate?
have an area?
Yes, sir.
You have a stroke VTI?
Yes, sir.
You get a stroke volume?
Yes, sir.
What is stroke volume? The amount of blood pushed out of the heart by
Per beat.
per beat.
Yes, sir.
Now multiply by beat.
Okay, okay. So that will give me the cardiac output. Okay, sir.
What is your stroke volume, Parvez?
Sir?
What is your stroke volume?
So the value?
Yeah, your value.
I'm not very sure, sir. How much is it?
Okay, what is the normal value of stroke volume? 4 to 7 liters, man. I showed you the slide already.
It's a lot of information in one day. I will try to. I always revise once you are done with the slides. I go back, I revise. So I'm more averse with the previous slides than the current slides most of the time.
Okay, no issues. I'm just joking, you know.
Okay.
Let's have some fun also. You don't read all the times.
Yes. So, could you, sir, recommend books like where we can just go back and maybe brush
We are
up?
sending you the books where it's already in the pipelines.
Okay.
I hope you'll get the book very shortly because we have sent to almost everybody. Not your batch is going to get the books.
Okay.
Everything would be there in those books. And we are sending you all the recordings. You can listen to these recordings anytime, whenever you have
Yes,
time.
sir. I'm going through the recordings there because that's very much easier to brush up and revise again and again, like if you have doubts. Because in current slides, sir, for me it goes pretty fast. It's difficult to grasp, so I always fall back to the recordings.
I'm trying to be as slow as possible, Parvez.
No, sir, it's okay, sir. You go with your speed because again, in any case, I have to fall back to the recordings most of the time.
Yeah.
Thank you, sir.
Any other questions before we have a break?
So,
Devangana, go ahead.
So TVI and VTI are the same. Okay.
Roti and chapati.
Right, sir. Okay. And sir, regarding LA, I had one more question. Can I?
Go ahead.
Right. Thank you, sir. Sir, so if the LA is enlarged and there is a valve defect, like a stenosed valve, sir, if LA is enlarged, the volume will be more. Please, like, if I'm understanding the hemodynamics correct, please tell me, sir. So if the LA is enlarged, the volume will be more. And if it's a stenosed valve, the pressure will be more when the valve is open and blood is trying to enter the LV. Sir, will there be any backflow to the pulmonary vein?
Correct. Now, what is your first question was? Your first question is the LA is enlarged and
Yes, sir.
volume would be high. Need
Yes.
not be. Because volume is a dynamic phenomena. Suppose you dehydrate a patient, the LA volume will go down.
Right.
So it's a dynamic phenomenon. Dilated LA suggests that there's evidence of already a large volume at some time. So they do not go simultaneously. They can go simultaneously, but need not be. Because LA is always LA size and large means the volume would have been high at one time or the pressure would have been high at one time. But at this present moment, the volumes may be normal. Second thing is, if the LA stenosis patient, the LA pressure become high, so there'll be a reverse of phenomena. No, that does not have a reverse of phenomena. What exactly happened? The flow, which is pulmonic flow, which is happening for pulmonic veins in both systole and diastole.
Okay.
So they'll get truncated because LA will not let the blood to come inside. Especially during diastole, when the LA volumes are very high, it will start holding a blood during diastole from pulmonic veins to LA. When do the blood get reversed in pulmonic veins? Whenever we have mitral regurgitation, severe mitral regurgitation, the blood flow touches all the way to pulmonic veins. So there's a systolic truncation of mitral flow. Or systolic reversal could be there in severe MR. Correct?
Okay. Okay.
I know it's too much of everything.
No, sir, I'm just trying to understand the hemodynamics here. So in stenosis, there will be no shunting of blood or like truncation of blood to the pulmonary vasculature.
The truncation of blood could be there during diastole, not in systole.
During diastole.
Because LA volume would be very high during diastole.
Okay.
And when you contract,
here diastole, by diastole I mean the ventricular diastole, because atrial and ventricular diastole are delayed by 0.1 second.
Yeah. So when we talk about diastole, we talk about diastole of LA. When we talk of systole, we talk of systole of LV.
Okay.
So systolic LV means diastolic LA.
Yes, sir. Yes.
Okay.
Yes. Okay. Sir, I'll try to process and
Devana is a learning period. You know, it's very common for everybody, not alone with you.
Thank you, sir.
The more you spend time, it's like a daldal. The more you get into it, the more you'll stuck into it. And believe my words, like I started doing echo when I was 1986, 14 plus 25. And still I say I do not know anything about echocardiography. It's an ever learning process, you know, like you cannot say yourself that you have learned everything. You have to read every day to update yourself. Yes. Like you asked this question just now. Yeah, like I always feel that I don't teach you all. I always learn from all of you. The question you asked me, reversal of flow in mitral stenosis, systole or diastole. Systole, we have no reverse because already the LV pressures would be underestimated because not much of the blood flow is happening from LA to LV.
Yes, sir.
But during diastole, when the ventricle is atrium is trying to contract against a stenosed valve, the blood which is coming from pulmonic veins will stop automatically.
Okay.
Got it? All right. Any other questions? Anybody else?
Sir, do we have a test?
Tushar, go ahead, Tushar.
Nothing important. I just wanted to ask, do we have a test next week? Like there was
so bothered about a text, man.
In schedule, it was written that next class is a test.
Yeah, we are little delay. Look, we always make a schedule, but we don't stuck to the schedule, to tell you very honestly. I may take one more class to show you a live demonstration before I take your exams. So I want to make everybody clear thoughts. Look, I'm not in a hurry. Even if I have to take sometime 2 classes in a week, I'm not bothered for that.
Okay, sir.
So next week, I'll try to show a live demonstration. Because next week is soon after Diwali, if I believe. Diwali is like these all, I'm sorry to say these words, पंडित जी जितने नए पंडित जी आए हैं इनको ये नहीं मालूम कि संडे कब है, मंडे कब है, ट्यूसडे कब है। इस बार 3 दिवाली है, 20, एक 21, एक 22। अब कौन सी है ये नहीं मालूम। So when if Diwali happens to be 22nd, it'll not be easy to take a class. If it happens on 21, also it'll not be easy for us because I have to show a live demonstration from a lab. I'll catch hold of a subject and show you everything live. You ask me a question, we have developed a software with which will show everything live. I'll show you the hand movements. I'll show you the screen. I can show you the knobs. So those kind of things which can I only show by live demonstrations. And those are really the things which you need to know, practical aspects. So I'll let you know based on this forecast by Panditji, when are we going to take a class on 22nd, 23rd, or maybe whatever it is. But we'll have a class. Any other questions before we stop over here? And I quickly take. Go ahead.
Excuse me, sir. So I just want to add one thing regarding the confusion of the systole and the diastole. I just want to add that if we can go through our older physiology book like the cardiac cycle, so we can get rid of confusing between the systole of the atrial and the ventricular systole. It gives a clear vision about the cardiac cycle. Whole cardiac cycle gives very clear vision about the various events happening in the cardiac cycle.
If you want to get rid of system, complete confusion is attach an ECG, man. Beginning of QRS complex to end of a T wave is systole. End of a T wave to beginning of QRS complex is diastole.
Okay.
So what you're saying, and I'm showing you live images. Look, my images will never have without ECG gating. Always with ECG. Every machine has got ECG card. Every lab has got an electrode. The only problem is nobody puts electrode, nobody puts in leads. If you happen to come to our lab, my words will not do any echo without ECG gating. Suppose, how do I say this? Pulmonic phenomenon is always constant, pulmonic venous flow, systole and diastole.
Yeah.
How do you say what is systole, what is diastole? I cannot. Hepatic venous flow, same thing. So we always do an echo with ECG gating. Okay. All right. Any other question? Kamal, any comments you want to make? So quick attendance, very fast and very quick. So this is combined ones. Roll number 1, Ravi Mandwa. 2, Arya Mahapatra, he was present. Dr. Arun
Yes, sir,
Kumar.
present.
Yes, sir. Arun Kumar present.
People who have asked questions, you don't have to worry. I've already marked your presence. Amit Kumar Yadav, 4.
Present, sir.
5, Debangna was present. 6, Rajan Verma was present. 7, Parveen Kumar Tasir. Vaibhav Anand Patel, 8. 9, Wagmare. 10, Saif Iqbal. 11, Anupam Kujur. 12, Banda Medu.
Present, sir. Present, sir.
Aditya Garg, 13.
Present, sir. Aditya, present, sir.
Okay, done. Naresh Kumar Jangade, 14.
Yes, sir. Present, sir.
15, Roshan Kumar.
Yes, sir. Present, sir.
Ruchi Sharan. Sai Prasad. Anupam Kuzur. Okay, Anupam, I marked you present. No worry. Ruchi Saran. Sai Prasad. Sitij Valvakar. Gurnoor Singh.
Present, sir. 19 Gurnoor present.
Gurnoor ji, ki haal hai father da ਤੁਹਾਡੇ?
Present, sir. Siddhisha Valvaikar.
Okay. Papa ठीक है?
Yes, sir.
Okay. Dr. De Silva, 22.
Sir.
Present, sir.
21 present, sir.
Kamal, you asked a question, so I marked you present. Sabir also asked a question, I marked him present.
Thank you.
Gaurav Singh, 23.
Present, sir. Gaurav Singh.
Dilip Chaurasia.
Present, sir.
Done. Tushar asked the questions. A. Swami. A. Swami. Patil, I have marked you present. Vaibhav Anand Patil. Vikas Chandra Vidyarthi. Rahul Kalita.
Present, sir.
Done. Shinmoy Viraj Naik, 29.
Present, sir. Shimoni.
Shimoni, I'm sorry. Monica, 30. Shubham Yadav, 31. Kanav Seth, 32.
Present, sir. 32.
Kanav Seth. Anu Yarki
Present.
was present.
Yes, sir.
Vaisuddin Bakshi. Amit Agarwal.
Present, sir.
Prashad Bhimrao Suryavanshi.
Present. Prasad Suryavanshi present, sir.
Chandrahas Patidar.
Yeah, present, sir.
Pratik Dalip Patil. Kailash Motera was present. Ajay Jairam Chaurasia.
Present, sir.
Anirban Singha. Parvez Bahar Chaudhary was present. Varun Gupta.
Sir, Anirban Singh present, sir. 41.
Okay, done. Anirban. Varun
Yes.
Gupta. Sheila Goyal. Dr. Neeraj.
Present, sir.
Neeraj is present. Neeraj, you will not change your iPhone, man. I'll take your iPhone otherwise then. Rakshpal Singh, present.
Yes, sir.
Divyesh Kumar, engineer.
Present, sir.
Naveen.
Present, sir.
Khuman Singh Mandavi. Shivpreet Singh Samra. Dr. Samra is there. Dr. Kunal Narang. Then online people, Anurag Chaudhary.
Present, sir.
Rafat Jahan Manzoor Ali Sayyed. Rehana Akhtar.
Present, sir.
Anima Firdos.
Present, sir.
Ajay Sharma.
Present, sir.
Ritu Purna Chanda. Mohammad Anwar Hussain. And Mahfouzur Rahman.
Present, sir.
Present, sir.
Mohammed Anwar present, sir.
Okay.
Mahfouz present, sir.
Done.
I'm A. Swami, 26 number present, sir.
Okay, Swamiji. Done.
Roll 16.
Just a minute, one by one. 16. Done. Anybody else?
The roll number 22 is present.
Please silent your mic. Everybody requests with folded hand. Please silent your mic. Roll number 5, I marked present. Debangna already. Ajay Sharma, roll number 5, online. Okay, Ajay Sharma marked present already.
The roll number 22 present.
Dr. De Silva, I have marked present already.
Sir, roll number 48 present.
48 present. आप कहाँ थे? सो रहे थे क्या आप? नवीन जी?
Roll number 12 present, sir.
12. दोबारा बार नहीं बोलो यार, एक बार हो चुका. Dr.
Venkatesh.
Already.
Yeah, okay, sir. Thank you.
Roll number 1 present, sir.
Roll number 1 present. Ravi Mandava.
Yes, sir.
Okay, done. Okay, last chance. Absentees are Parveen Kumar Tashir, Kiran Kumar Wagmare, Saif Iqbal, Sai Prasad, then Vikas Chandra Vidyarthi, Dr. Monica, Shubham Yadav, Vaisuddin Bakshi, Pratik Dalip Patil, Varun Gupta, Sheila Goyal, Shivpreet Singh Samra, and Dr. Kunal Narang. Then in online, Dr. Rafat Jahan Mansoor Ali Sayyed and Ritu Purna Chanda. All right, guys. Have a great day. Great learning. And we see you next week. I hope I will tell you the date very shortly. And we are going to have a very good
Excuse me, sir.
Yeah, go ahead. Tell me,
Sir,
dear.
roll number 38 present, sir. Sir, I had a bad network, sir. Roll number 38.
Oh,
Dr.
no,
Pratik Dilip Patil.
I have marked you presently. Okay,
Okay, thank you,
guys.
sir.
So we have going to have a live demonstration next week. And with this few words, see you next week. Bye-bye. Take care. Shabba khair. Bye-bye.
Thank you, sir.
Good night.
Good night.
Good